All right. Welcome, everybody. We're going to get started. So please take your seats, settle. And for those who are joining us virtually, take your seats as well, I guess. I don't know. Welcome, everybody. This is a unique and new event that we're doing. For those who are typically here on this first Friday of the month, you are usually here for the Clinical Ethics Consortium. If you're often in this space or locale or Zoom for the fourth Friday of the month, you're here for the Organizational Ethics Consortium, and we're doing a really exciting new thing today where we've combined the two for a session that is a collaboration between the Clinical and Organizational Ethics Consortia. And so before delving into what we're going to talk about today and some introductions, since I know we have some folks who are usually attendees at one or the other, I want to give a little bit of information about each of the two consortia just to make sure everybody understands kind of the thought process behind this. So first, starting with the Organizational Ethics Consortium. So as I alluded to, this is one of Harvard Medical School Center for Bioethics monthly consortia. That is co-organized by my wonderful friends and colleagues, Kelsey Berry and Charlotte Harrison. Charlotte is joining us today via Zoom, and Kelsey is away on parental leave. So this is a forum for local, national, and international discussions with a really diverse and spectacular group of stakeholders that explores some ethical issues at the level of either the institution, the organization, or the hospital system. And what this consortium looks to do is cultivate learning and communication across clinicians, scholars, administrators, and others regarding some of these really complicated ethical issues, and to identify some processes potentially by which we can address these issues, again, at the level of the organization, the institution, these higher level concepts and challenges. If you're interested in some additional information, the website for the Organizational Ethics Consortium is at the bottom of the slide here. And our other consortium, which is often typically at this time of the month, Clinical Ethics Consortium. This is again monthly, usually at the first Friday of the month. Sorry, my slides are advancing on their own. And this is a multidisciplinary forum for ethics program leaders and ethics community members of the Harvard-affiliated hospitals, along with the HMS Bioethics faculty, students, and trainees. What we see the Clinical Ethics Consortium as is an opportunity to explore and learn from some of the real clinical ethics cases from across the Harvard-affiliated hospital system, and to consider the lessons that we can learn, how we can maintain or improve the provision of clinical ethics support at each of these hospitals. Importantly, in contrast to the Organizational Ethics Consortium, which is open to the public, typically the Clinical Ethics Consortium is closed to the public in the interest of privacy and respect for those involved with these challenging cases. The Clinical Ethics Consortium is organized by myself and my colleague who's sitting next to me here, Leanne Homan. And again, if you're interested in further information about the Clinical Ethics Consortium, you can visit the website at the bottom of the screen. But that leads us to today. So this is, as I alluded to, something that is a combined presentation of the Clinical Ethics Consortium and the Organizational Ethics Consortium, where we're going to be exploring public engagement regarding patient-facing hospital policy, the ethics challenges and opportunities of public engagement in healthcare settings. So we're combining our forces for this spectacular section. I'm really excited, and I'm excited to introduce everybody on behalf of my co-organizers. And I'll introduce each of our speakers in just a moment before I give, but first I want to give just a little bit of background to set things up. So we're going to be talking today about public engagement, and particularly in the healthcare setting. So there's a growing recognition of the, sorry guys, the value of engaging the public and engaging the community when we make healthcare policy decisions. Importantly, there are a lot of different ways in ways that this might take place. So whether we refer and different things that we might refer to this as, whether we refer to it as engagement, participation, deliberation, or even something else. Well, our speakers may get into a little bit of some of the differences and distinctions between each of those. And then who it is that we're trying to engage, participate with, or deliberate with, whether it's the public, the community, patients, families, advocates, or some combination of all of those. Importantly, as it stands today, this certainly is not standard or consistent across all policy settings, but it's probably exists more today than it did several years ago. So one of the questions that we'll explore today is, one, why isn't this done more? And two, perhaps what are some of the obstacles to doing this more regularly, and what might some of the hazards be of this type of engagement or participation or deliberation? And so that being said, before we delve into the details, a little bit of context. Many of the folks, at least who are here in person, probably virtually as well, might be a little young to remember this, but patient autonomy, the concept of patient autonomy and patient centeredness in healthcare are actually relatively new concepts. It wasn't that long ago that patients really had very little, if any, role in healthcare decision-making about their own healthcare. A couple of decades ago, it was relatively standard for patients to be told by their clinicians what to do, and patients did it. It was even not that uncommon, if not quite the standard, that patients weren't always told their diagnosis. It just said, this is what you need to do. Thanks, call me if you have any problems. There's been a very clear and drastic change, a very significant evolution over the past couple of decades with this, and our whole model of care has evolved alongside this. This has taken place over really the past 50 years or so. But with that context in mind, the drastic change that's taken place in patient care at the bedside, it's perhaps not quite so hard to understand why patients aren't so, and the public in general isn't quite as engaged as some might like them to be in policy decisions. But that said, many hospitals do engage with the public, engage with the community, engage with patients in a variety of ways outside of the policy setting, whether that's patient family advisory councils. You may hear the abbreviation PFAC for this over the course of today's session. Various ways of engaging the community about new clinical sites, whether hospitals or clinics or things like that. General community outreach is something that hospitals and clinics oftentimes do. And then it's not uncommon for healthcare organizations to organize public fora, public conferences, things like that. All right, and so before I turn things over to our speakers, I want to give a couple of examples of what it is that we're talking about here. So, one, the New York State ventilator allocation guidelines. One of the examples that many people will refer to when we talk about public deliberation or public engagement about policy. Importantly, while this wasn't an individual hospital policy, in some ways this is the gold standard. For those not familiar, New York State first drafted guidelines about allocation of scarce resources, specifically scarce ventilators, after some degree of public engagement back in 2007. And then there was some even more significant and quite intentional public engagement via an intentional project that was that took place across the state, starting in 2011 through focus groups and public outreach efforts. And then ultimately, after integrating the responses from that engagement into their work, there was a revised set of guidelines that was published in 2015. These guidelines actually ended up being a very foundational when we started thinking about allocation of scarce ventilators during COVID. This was really the starting place that many hospitals, states, and organizations used in thinking about that. So though this was not an individual hospital or hospital system engaging the public, in some ways this really, to many, is a model for how public engagement and deliberation can be done well. Second, as many people are probably aware, public deliberation existed in some way, shape, or form for many COVID-related policies over the past handful of years. COVID brought a huge amount of attention to patient-facing policies, not only because of the great strains on the healthcare system that the pandemic placed, but also because of, for better or for worse, the divisive nature of some of the policies that were considered or implemented due to politics and the divided nature of our country and many other things. So this came up with regard to masking policies, things like visitation policies in hospitals, ultimately the lifting of masking policies over the past year or so, vaccination requirements for hospital staff and employees, all kinds of different things. So probably there's been more attention to some of this stuff over the past couple of years than there really has been in almost any other time in the past. And finally, if this weren't complicated enough, the role of public engagement kind of becomes even more complex when we're talking about interventions or policies around which there's significant political and even legal turmoil and controversy along with that turmoil. And so when we're thinking about these quote unquote controversial interventions, I say controversial in both real and figurative quotes because it's not necessarily that these are controversial interventions writ large, but at least for certain individuals or certain populations who push back against them. So when we're talking about things like abortion in the post-Dobbs era, care and surgery for transgender patients, conscientious objection or conscientious provision policies, these concepts become even more complicated, and how we think about public deliberation and public engagement becomes even more complicated because it raises questions about how we can or how we should engage the public about them. And even more challenging when it's around these issues, the public is so distinctly divided, and that which then raises questions about how we navigate this and think about the fact that the public, as it were, might in one region might be very different than the public or the community might be in another region or another city or another state or another part of the country. All right, so that's enough from me. Before I hand off the baton to our wonderful speakers, thank you all for joining us. We will save questions until after our three speakers have spoken. But in the meantime, those who are joining us virtually at any time during the session, you can post questions into the chat. We will be keeping an eye on these during the meeting and be able to have some selected time at the end of the session for answering some of those questions, both during the chat that were put in the chat and those posed by those here in the room who raised their hand and those who raised their virtual hands during the Q&A session as well. If anybody who's joining us virtually has technical issues, you can use the chat feature to send a message to the panelists and one of us will try to help you. And then finally, to those interested in other events and things through the Center for Bioethics, you can subscribe to our newsletter at the web address you see on the screen here. All right. So without further ado, I am absolutely thrilled to introduce our speakers for today's session. So as I mentioned, we'll have our three speakers speak sequentially, and then we'll move on to question and answer after that point, after all three of them are done. I will give a more extended introduction of everybody before they speak. But we're joined today by Dr. Erica Blacksher, Dr. Julius Yang, and Dr. Basil Tarab. And then after each of the three have spoken, we'll have a brief discussion amongst our speakers, moderated by our own Charlotte Harrison, followed by a question and answer session. All right, so to introduce our first speaker today, Erica Blacksher is an ethicist and engagement scientist. She trained at the University of Kansas and University of Virginia, which led her on a path that's included many really incredible roles, including as tenured faculty in the Department of Bioethics and Humanities at the University of Washington, as a research scholar at the Hastings Center, and a Robert Wood Johnson Foundation Health and Society Scholar at Columbia University. She's now the John B. Francis Chair in Bioethics, an endowed chair at the Center for Practical Bioethics, and a research professor in the Department of History and Philosophy of Medicine at the University of Kansas in their School of Medicine. Dr. Blacksher studies questions of responsibility and justice that are raised by U.S. health inequities and the policy and the potential for democratic deliberation to make health a shared value. Her current work focuses on health justice theory and intersectionality, on whiteness, poverty, and health, and on deliberative models and methods, all of which are spectacularly relevant to what we're talking about today. So that said, I'm going to stop sharing my screen and pass the baton to Dr. Blacksher.
Thank you again for that kind introduction. It's a pleasure to be with you all today, pleasure to be a part of this panel. And I'm sorry that I can't be there with you in person. The title of my presentation is Public Deliberation and Policymaking in the U.S. Health Sector, Opportunities and Challenges. And before we begin, let me just note that I have no conflicts of interest to report, and that my views are my own and not necessarily shared by the institutions and organizations with which I'm affiliated. Before I turn to my objectives, I just want to say that my remarks today are quite narrow in focus by necessity. I'm talking about the civic practice of democratic deliberation in the form of small public forums that have been there's been such a groundswell of interest in over the last several decades. This narrow focus will leave much unsaid, much interesting stuff unsaid about democratic deliberation. Its roots in political theory and moral theory and communication theory, the ebb and flow of this civic practice over the course of US history, and its formulation as a kind of vibrant, engaged, discursive democracy. Though I do think on that latter point, you'll get a sense of what such an ideal might look like as we begin to unpack what public deliberation is and what it seeks to achieve. So with these caveats in place, let me just turn to my objectives, which are four. First, I'll define public deliberation and situate it within a participatory turn, a broad participatory turn in the US health sector. I'll describe the purported benefits of deliberation and then what the empiric evidence has to say about those benefits. I'll identify the best opportunities for deliberation. We shouldn't deliberate about everything. And I'll identify challenges to deliberation. So with regard to that first question, what is public deliberation? And I should say there is no consensus definition. There are many definitions, many notions out there about what deliberation is, including one that colleagues and I developed and published over a decade ago. But the one I'm going to share with you and that I'm sharing with you on this slide, I think would pass muster with most deliberation scholars and practitioners. And that is that public deliberation is reasoned dialogue and debate among diverse citizens about matters of public concern in search of solutions. Now, packed into that definition are many key nuggets, characteristics of deliberation, who it should involve, what it should involve, and what it seeks to achieve. So I want to underscore just a few of those characteristics with these bullets. So first, it involves regular people. The idea here is that ordinary citizens should have a voice, a say in issues that affect them, that the views and values of subject matter experts, technocrats, political leaders, economic elites are not the only views and values that should shape important social questions of the day. Another important feature of these citizens is that they are diverse, by which I mean they come from many backgrounds, have a wide range of perspectives, different lived experiences, different identities. Second, with regard to the kind of conversation that deliberation seeks through its very careful design and implementation. The first, importantly, is that it wants deliberants to consider the facts, the evidence, what we know, what we don't know. Deliberations always offer, through different formats, whether it be written materials or expert presentations, information that is factual, balanced, and inclusive of what we know and, where relevant, what we don't know. The third, deliberations are designed in ways that try, anyway, to promote a dialogue that exhibits mutual respect among participants, curiosity, and reciprocity, and involves careful weighing of people's perspectives and a range of values, and of course, that evidence. Um, and then finally, this is something that is often spoken to. It doesn't always happen, but there is this idea of transformative potential with deliberations. That is to say that viewpoints may evolve in light of evidence or exposure to viewpoints that are quite different from one's own, or even just from having the opportunity to reflect on why one thinks what they think, what those underlying reasons and justifications are. So transformative potential. The last thing to say is that deliberations are typically civically oriented, which is to say that they're oriented toward the way the questions are framed, and the way the deliberations are designed and structured. They're oriented toward shared problems and collective problem solving. Now, interest in deliberation over the last several decades has spawned a wellspring of deliberative activity and experimentation in the United States and around the globe. There are organizations and handbooks devoted to teaching people how to deliberate, and that also creates space for people to deliberate. Models and methods of deliberation have proliferated. There are citizen juries, citizen assemblies, planning cells, study circles, national issues forums, deliberative polling, and more. And such forums are used to address a wide range of social issues across many sectors: transportation, technology, and the environment, education. There's something called participatory budgeting, where people get involved in the budgeting of their municipality or their city. And deliberation, happily, has gained traction also in the US health sector. Its uptake is part of this broader participatory turn that's rooted in the idea that things go better, things are better, when people's views, their insights, their lived experience inform, in the context of health and healthcare, clinical decision making, the practice of healthcare, the design and implementation of health research, learning health systems, AI-driven diagnostic algorithms, and more. And also now the development of health policy. We see this manifested in the form of things like Community Advisory Board and what Dr. Marin referred to earlier, patient-centered care, shared decision-making, but also the patient-centered outcomes research, which is now a formal federal institute. And in 2012, there was a controlled trial of deliberative methods funded by the Agency for Healthcare Research and Quality, ARC, called the Deliberative Methods Demonstration. ARC funded a controlled trial of deliberative methods, which was no small undertaking and took many years, because although there were many purported benefits of deliberation, empiric evaluations of deliberations lagged seriously behind that enthusiasm and that experimentation. Now, that enthusiasm has something to do with the putative benefits of deliberation. So when people are making normative arguments for why we should deliberate, they often point to things like this: that if we did bring people together with information, and with certain sort of democratic norms as guardrails for the discussion, with diverse people truly from all walks of life, then our judgments, our decisions, our policies, our practices would be more informed and more considered. That we would get fairer, more just policies and decisions, more sustainable policies, more sustainable in part because people would view them as legitimate. And it'd be also one way to show respect for voices that are very often, if not silenced, marginalized and sidelined. That it would improve institutional accountability and transparency, and that it would generate trust, public trust in institutions, something that we all know has bottomed out. The Americans do not trust one another. They do not trust the government. They do not trust institutions. They do not trust expertise or experts. Now, although empiric evaluations of deliberation continue to lag behind deliberative practice and controlled trials remain rare, there have been more empiric studies, and we have learned a few things. When done well, studies suggest that deliberation can deliver on some important goods, and I'll turn to those next. There we go. So what does the evidence show? So I'm pulling from a whole host of studies, and I should have said this at the outset, but at the very last slide in my deck is a source page where there are references to a number of many studies and articles that I'm using and drawing from. So what we know is that people who participate in deliberations can gain knowledge regardless of education level and when that information is very complex. For example, the ARC controlled trial that I mentioned, they were looking at how they were asking deliberants how evidence of effectiveness should be used in clinical decision making. That's a very complex topic. And what they showed in this controlled trial is that people with a high school degree or less could, across all races and ethnicities and other sorts of sociodemographic variables, could learn and discuss that kind of information. Again, that's in part due to making that sort of information available in plain language. We also know that people gain insight and appreciation into other people's very different sort of circumstances, their situations and perspectives, and that people really value the experience to participate. People do develop trust in their fellow participants, which we call deliberants, and sometimes also in society more generally. People become more public spirited in their reasoning and judgments. I could offer you the example of a study that where people were having to make decisions about how to allocate resources in a healthcare plan. And people ended up giving up benefits for themselves in order to ensure that more people could be covered. That's one example. And a very important study done by James Fishkin and colleagues in 2020, at the height of a whole lot of partisan animosity, they did a deliberative poll that showed that people exhibited less partisan animosity, that sort of hostility, that emotional hostility, and yet less polarization around the issues themselves. And other studies have been done that show that people actually gain deliberative capacity and confidence, and that they become more civically active. They begin to vote more, they begin to volunteer more, and other civically engaged type of activities. Now, much more evaluation needs to be done. I mean, these studies don't make it so. There's a lot of variation in the quality of deliberation and the design of deliberation. And we need to understand better what sort of design features lead to certain outcomes. As an experienced mentor told me recently, he said, it's not always easy to measure the magic that we witness in the room. But still, this is some good news. Now, I'll admit to being a deliberation enthusiast, but not all matters are suitable to deliberation. So when should we deliberate? And some of the key issues are when there's no one right answer. That is when the issues are value laden and complex, and there are competing and conflicting values, and when normative trade-offs need to be made. And also when there's no technical solution. There's no, maybe we know what we ought to do, but we don't know how to do it, and how to do it may be a question best left to people with a very specific type of knowledge and a very specific sort of expertise. But when real world knowledge and experience need to inform decisions, and when those are going to affect members of the public, ordinary citizens, as we might say, then we should invite them into the conversation. And when there's no easy answer, where there's low trust, where there's controversy, where issues are sensitive, deliberation can be used in these contexts as well, which might sound odd because you might think, oh, that's the last moment when we should be having a public deliberation, inviting people into the conversation. But I would argue that's precisely when we should invite people into the conversation. Now, there's this also issue. You see a question mark here, and we could talk about this. We can talk about all of this, of course, because I'm just saying the most briefest of things about each of these points. But very often deliberation is used when there is some linkage to people who will make decisions, will make policies, or will inform practices. There's some disagreement among deliberation scholars and practitioners about whether that's really the only reason to use deliberation, but it's a point to consider. Now, I want to pivot to some of the challenges of deliberation. I think I might have about 2 or 3 minutes left. And let me just say that there is, I said I'm a deliberation enthusiast. Well, there are critiques from the left and critiques from the right about deliberation. People on the left will sometimes say and argue, including theorists, that deliberation is a distraction from far more important forms of democratic action and agitation, that there's the risk that it will privilege elite voices and majoritarian perspectives, and that it will marginalize the views and voices of those who are racialized, who are impoverished, or otherwise sidelined. Critique from the right is that public deliberation is liberally biased, that the values that guide its goals and that guide its sort of structure and design reflect the values of diversity, inclusivity, equality, tolerance, and mutuality. So, but many of us remain committed to its exercise. So, sorry, I'm just trying to move forward, not backwards. There are still more challenges here. And so here I started thinking a lot about healthcare leaders and healthcare administrators and thinking about doing this in hospital settings. And I think there's some questions you'd really have to ask. So at the macro level, sort of administration level, a societal level, it's really important to identify what are the appropriate decision-making junctures for public input. And then also deciding what it means for public input to inform decision-making, right? So that's that point about, do we only deliberate when there's a policy that we're trying to make a decision about, or would we want to do deliberative research to understand what people's values are in this realm so that we can kind of have a sense of the community, a sense of the populations that we serve, and those values then could be used to inform principles of policymaking? I mean, these are questions to discuss. But I think, hospital administration would want to say, well, is this one data point in a number of data points that we would consider? And part of the reason it matters is you don't want to convene people without telling them why you're convening them. That will not make people happy. People need to understand why I am here. And then paying for it. Participation, deliberation is a resource intensive activity. It takes time. It takes people with expertise to execute and deliver it. And you've got to pay people to be there. So it takes dollars. I mean, at the meso level, kind of organizational community ecosystem level, there's building and maintaining the partnerships with community leaders and organizations for that sort of doing deliberation. And then, of course, there's the question of and the concern about countering it being the processes and the circuit of deliberation, if you will. If you imagine sort of building out infrastructure so that hospital systems can maybe deliberate periodically, and this is more of a sort of a something that you all do periodically rather than just a one-off, making sure it doesn't get co-opted by elite, majoritarian, or special interests. At the micro level of a design and implementation, let me just say, because I think my minutes are up, there are all manner of complexities, and I've been immersed in this for years as I've designed and implemented many deliberations, including one I'm leading right now, which is creating a deliberation toolkit for entertaining and deliberating around population health challenges like life expectancy and infant mortality, et cetera, right down to question formulation, what that information base looks like. Health and healthcare are politicized, facts and the public are polarized, and it's not easy stuff. We also have to manage power and identity dynamics. But with that, I'll just hope that laid out some breadcrumbs for us to chew on later. And here are the sources that I have used. You'll see they're divided into what deliberation is, a number of sort of key and some seminal sources, and what deliberation can deliver. And with that, I'll stop. Thank you for your time and attention, and forgive me for going a few minutes over.
Thank you, Dr. Blacksher. Those certainly were lots and lots of excellent breadcrumbs that'll, I think, be a wonderful foundation for the rest of our conversation today. I'd now like to introduce Dr. Julius Yang. Dr. Yang is a physician, hospitalist, and expert in quality improvement in hospital administration. He went to medical school at UMass and received his PhD at the Massachusetts Institute of Technology before completing his internship in Beth Israel Deaconess Medical Center. He's now been a leader at Beth Israel, where in addition to being a beloved member of the faculty, he's a practicing internal medicine hospitalist, along with vice chair for clinical affairs in the Department of Medicine and senior medical director for clinical operations and analytics at the Silverman Institute for Healthcare Quality and Safety, all of these roles at Beth Israel Deaconess Medical Center. Dr. Yang is a beloved teacher, clinician, and organizational leader, and I'm thrilled to have him joining us today. Yang.
Thank you, John, and thank you, Professor Blacksher. It really is an honor to be a part of this event today. Dr. Blacksher, that was a wonderful overview and framework, hopefully to frame our conversation as we go forward. I'm going to try to share my slide here, and I've tried to offer a little bit of a perspective of, as a hospital administrator and practitioner, how we think about patient and public engagement, and give at least a sample of some of our experiences in doing so. And as John nicely pointed out in our introduction, sorry, let me just get this here, that it wasn't that long ago that patients themselves weren't necessarily engaged in decisions, important decisions about their own healthcare. And I recognize that as a physician at Beth Israel, I am very honored to be part of a legacy where transparency and engagement has been part of our journey from the early stages. And just highlighting a few things here, that back in 1972, I think we were, if not the first, one of the first hospitals in the country to adopt a patient before the American Hospital Association did so nationally. And as described here by Dr. Rabkin, really understanding how, most importantly, to engage our patients in their care as a matter of respect, as a matter of building trust, and really allowing them some agency and control in terms of important decisions at that time, including decisions about how they wanted to receive care at the end of life. Fast forwarding a few decades, just recognizing that Beth Israel Deaconess Medical Center was really one of the early hospitals to embark on the Open Notes project, which now involves many hospitals. Steve O'Neill, who's a part of the audience here, was there at the inception and an important leader at that time. And again, borrowing from Tom Delbanco, who was one of the lead physicians in developing this, I think he taught me that the mantra of nothing about me without me was really central to the principles that generated this practice, which has largely become routine and now is actually required by law across the country in terms of allowing patients access to their own medical records. But as John pointed out, the journey of patient engagement has been one, at least in my healthcare career, has been sort of a basic standard value that I know nothing but. I know that we can always do it better, but this is an accepted value that we should always be engaging our patients in all aspects of their healthcare. But I'm recognizing as a health system administrator leader that our ability to engage the public in the same way about important decisions that impact their health outcomes is less universal, it's less standard, and we tend to do it in a more selective fashion. I'll share a little bit about what some of those selective practices have been that I think have been very important for our organization and its growth and its development. And as Dr. Blacksher said, moving from just a purely informative standpoint to a transformative role in how our organization functions. And I'll highlight a few things, all of these led by individuals other than myself. So the Community Benefits Program and Community-Based Health Initiative that are spearheaded by our Vice President for Community Benefits and Community Relations, Nancy Kaysen, and the Patient Family Advisory Council. I think Laura Dickman, who's our program leader for Patient Family Engagement, is on this call. So I look forward to their comments as well. But just as an example of our community benefits program, for those of you who are not familiar, as a nonprofit tax-exempt hospital, there are commitments that we need to make in order to address the needs of our communities. And this charitable care standard compelled hospitals to engage in activities that benefit the communities that they serve. And with the Affordable Care Act, there was an additional requirement to conduct a community health needs assessment with an accompanying implementation strategy every 3 years. And I'll just give you an example of what that looks like for us. And here's our implementation strategy. This is publicly available on our website here. And these were the guiding principles, which I think nicely summarize really what we're trying to accomplish in the principles of accountability, of community engagement, and just to get into that text a little bit more specifically, to collaborate meaningfully, intentionally, and respectfully with our community partners and support community-initiated, driven, and/or led processes, especially with and for populations experiencing the greatest inequity. Equity as its own principle of what we are trying to improve, as well as having direct impact and real impact on those communities. This graphic here, which is included in the summary, I think nicely describes this continuum that we are trying to move constantly towards the right here. So at a very bare minimum in terms of community engagement, to inform the community about our activities, but really to be able to consult them, involve the public, collaborate, and ultimately empower those communities so that the healthcare delivery, the healthcare initiatives are community-driven and led. And just some excerpts from really how the Community Health Benefits Program operates is that through its advisory council and community residents and through the community listening sessions, they were able to formally prioritize community health issues and cohorts that they believe should be the focus of our implementation strategy. And that the prioritization process helps to ensure that our institution maximizes the impact of community benefits resources and its efforts to improve health status, address disparities in health outcomes, and promote health equity. So I know some of what I'm speaking with doesn't relate specifically to, I would say, policy in terms of what rules and protocols we are going to adhere to. But it is policy in terms of where our priorities are, where our values are, and what our processes are going to be. And that's reflected well, I think, in these Community Health Benefits Program statements here. That really what we're trying to accomplish is authentic community engagement, where our community members are informed, consulted, involved, and empowered. And just getting into the micro a little bit, as Dr. Blackshear was describing, some of the practices was across all 4 components. The assessment included 85 one-on-one interviews with key collaborators in the community, focus groups with segments of the population facing the greatest health-related disparities, and community listening sessions that engaged over 200 participants. And this is basically the end result. This is the priorities that were derived from that process of engagement, where we recognize that our populations that we wanted to prioritize were low resource populations who are racially, ethnically, and linguistically diverse. Importantly, as an adult care hospital, we committed that our priority population actually would include our youth population, LGBTQIA+, older adults, and then those families affected by violence and/or incarceration. Again, these priority populations were identified with the participation and engagement of the community there. And then these were the final priorities that come forward as an outcome of that. So for those populations, thinking about the major domains of equitable access to care, focusing on social determinants of health and include housing, food, jobs, and financial security, mental health and substance abuse, including the youth population, and then thinking about those patients with chronic and complex conditions. And this is just one example of one domain of basically what's the end product of that deliberative process to come forward with a strategy to affect specific cohorts and initiatives, and how we're going to measure that, who our partners within the community are going to be, and if there are any secondary priorities. So just an example of how our community benefits program at least is a very intentional and public way that we try to involve our communities that we are trying to serve, so that we are not necessarily dictating what their priorities are, but engaging them fully in terms of defining those. Related to that, also led by Nancy Kaysen, is our community-based health initiative. And this actually came forward as part of our new building project. So we built our first new tower in more than 20 years. And as part of that, the Department of Public Health required us to go through a determination of need process. And that determination of need process is used to promote health for all residents and to ensure health resources are fairly distributed across the state. And what that process directed us to do was dedicate 5% of the total project costs towards a community-based health initiative to help improve the health and well-being of all members of our service community. And according to Nancy, that amounts to roughly $30 million. Our building itself is 10 floors high, but what our president describes is basically the 11th floor of the new building is spread all across our community through these initiatives. So I think the question was, as we developed or we had access to these funds, what were we going to spend it on? And I think what we tried to do is engage in an honest and authentic health initiative that involved our community in thinking about what those priorities would be. There was a community benefits advisory committee that made up not only of leaders, but also local residents from the service communities of our area, and then to inform and guide the community-based health initiative process. And importantly, that this group was able to set the priorities for how those monies essentially were going to be distributed in grant format. And not only did that group have input into what the priorities would be, but what Nancy emphasized to me, that they had authority to decide how that money was going to be spent. And that was a commitment from our leadership, both our administrative leadership as well as our lay board governance. And so housing affordability, jobs and financial security, behavioral health, healthy neighborhoods were the priorities that were determined by this process in this group. And then this is too much detail, but this is essentially where the grants were directed. And these programs, again, really all distributed through a very community engaged process. Now I'm going to skip on to a little bit, so thinking less about our outward relationship with our communities, but thinking more about a lot of what happens within the four walls of our hospital has very much been informed by the development of the Patient Family Advisory Council. And I was an intern at our hospital before we had a Patient Family Advisory Council, and served on faculty as the Patient Family Council was just coming into inception. And that was in 2009. Here's our original letter that we received from our Department of Public Health around the topic of Patient Family Advisory Councils, which purpose was to inform us of our obligation to establish that. And in doing so, that this hospital shall establish a PFAC to advise the hospital on matters including but not limited to patient and provider relationships, institutional review boards, quality improvement initiatives, and patient education on safety and quality matters to the extent allowed by state and federal law. So this came initially as really a regulatory mandate. And the formation of the PFAC was intended to facilitate patient and family participation in hospital care and decision-making, information sharing, as well as policy and program development. And I think a lot was learned from the Institute for Family-Centered Care, and really identifying that the concepts of dignity and respect, information sharing, participation, and collaboration was central to these efforts of forming these patient family advisory councils. As it is now, we currently have 3 standing PFACs within BIDMC. So we have a hospital-wide patient family advisory council, as well as family advisory councils for adult intensive care, as well as our neonatal intensive care family advisory council. I know Basil is going to speak in more detail about exactly what the dynamics and the opportunities and challenges of PFACs are. So I'm not going to get into that too specifically. I'll say that an agenda typically for our hospital-wide PFAC looks something like this. So a presentation from hospital leadership on really what our mission goals and operating plan are across the hospital. So really an understanding of what our strategic footprint is going to be, but then specific initiatives around promoting health equity, addressing workplace violence, and operational initiatives such as urgent care expansion, thinking about our DEI goals and initiatives, and then ongoing work with open nodes. So this is basically what the agenda of our committee meetings might look like. But beyond those specific committee meetings, our program leader for patient-family engagement is really a central resource for involving patient and family members and integrating them into multiple domains within the hospital of how we actually learn to take better care of our patients. So one is committee memberships that includes our Safety, Quality, and Safety Board Committee, our Ethics Advisory Committee, as well as our DEI Council. We have patient and family members involved directly in our curriculum as faculty members, essentially, in training clinicians. In terms, this is just a sampling because I know it extends beyond this, but our OBGYN department has it embedded within the resident curriculum. We have a master's in healthcare quality program that's run where we engage patient and family members as faculty there, as well as emerging department nurses. And then ad hoc initiatives, which are really focused on specific areas or domains where we're trying to improve. So I had the privilege of helping to run the quality improvement retreat for our department in this past year, and that included two patients and one family member of patients who were in our intensive care units during the COVID time. And we were thinking about what their transition out of the ICU felt like and looked like and how we could improve on that. And then some work with our clinical and informatics teams as our clinical systems are going to be changing and impacting our patients as well. I think if I have just a couple of minutes, I'm just going to describe a little bit about what my very early experience was like as early healthcare struggling leader for our system in terms of thinking about how to run a better hospital. And this is really within the first year of the PFAC. And I have to say, when we learned that we were mandated to develop patient family advisory councils, we said, okay, fine, we can do it. We can easily check that box. We'll recruit some patient and family members. We'll form a committee. We'll have meetings, and there we go. And I recognized that I really was blind to really what the opportunities of having a group of individuals like this to meet with on a regular basis and to understand really what we're trying to accomplish and help us do that. So I thought that a good topic to bring to this council. At the time, I was very much immersed in efforts to reduce avoidable readmissions to our hospital. So patients would come in and get hospitalized, they would leave the hospital, and unexpectedly, within a month, they'd be back in the hospital. And we're trying to figure out, well, how do we do that better? And we recognized that part of our discharge process included a packet of materials that we provided to the patient on their way out. And when we ourselves as providers looked at those materials, even though we wrote it, we recognized that it was not a very helpful document, that it was very dense. It wasn't written in a way that's easily understandable for the patients. It wasn't even organized in an acceptable way. And so what we wanted to do, we knew we wanted to revamp it. And I wanted to essentially show this group of patient and family members really a prototype and ask them to kind of choose between prototype A and prototype B. And what I learned in my experience in presenting to them, these are my original slides from 2010, and I had these questions for them, and asking these questions, what I was able to learn was they were interested in those materials at discharge, but they kind of put that to the side, because what they identified for me is that communication with our providers is a problem, but not only in the paper materials that we're providing to our patients, but throughout the course of hospitalizations, our patients and family members are constantly feeling underinformed about what's happening to them. And that what this committee said is that that's really where we should put our focus. Fine, we can develop better materials. We should do that. We will do that. But really efforts to focus on better community engagement with our patient family members while they were in the hospital is something that we needed to solve. And that really set forward a decade of work that we've been trying to do since that time. And so recognizing, I think Dr. Blacksher, you used the word transformative. I think that's what we recognize, is that the Patient and Family Advisory Council was not just sort of a council to approve all the decisions we had already made. It wasn't just an information gathering resource. It really has been a transformative entity within our hospital that, again, sort of nothing about us without us has really been framed as part of really what the role of the Patient and Family Advisory Council offers to us as an organization. I didn't get too much yet into our challenges, but recognizing, again, although my commitment to engaging my patients in their own healthcare outcomes is universal and standard in how I try to approach all of my patients, I would say that we are still somewhat selective in what topics, what challenges we may present to a public forum or a group even of our PFAC in terms of, well, help us decide what we should do. And as John mentioned in the beginning, throughout COVID, obviously a stressful time for everyone, was thinking about, okay, we have to develop masking policies as the events are changing on the ground. We have to think about visitation policies. We have to think about vaccination rules. Even drug shortages during the COVID pandemic and since then have been managed. And then thinking about issues of workplace violence. Now, we have involved patients and family members in some of these committees, but I would say not universally so, and not necessarily in the same deeply engaged deliberative process that some of our community-based efforts have been, as described in the community benefits program. So I'm going to stop there. I'm going to allow Basil to introduce more to really what the ground level work is within the Patient and Family Advisory Councils. Thank you for your time.
Thank you so much, Julius. That was spectacular. I'm going to hand things over now to our third and final speaker for today before we move to our moderated discussion and question and answer session. Basil Tarab is a physician, bioethicist, and patient advocate. Dr. Tarab attended medical school at the Macau University of Science and Technology and practiced as a physician in Egypt and Syria before moving here to the United States, where he became a patient advocate and patient relations specialist. He was initially on the Boston Children's Ethics Committee, followed then by enrolling in the Harvard Medical School Fellowship in Bioethics, and then completed his master's degree in bioethics in our Harvard Medical School MBE program. He's since moved to Winchester Hospital, where he now serves both as the co-chair of their ethics committee as well as the director of patient experience, volunteers, and transport. In addition, Basil is both member of the teaching faculty here at Harvard Medical School Center for Bioethics and adjunct faculty at Boston College. Dr. Tarab.
Well, thank you, John, for that kind introduction, and thank Dr. Blackshires and Yang for the knowledge that you shared with us. And I will try to build on what you started. But first, I want to just make, so I'm not going to be presenting slides, I'll be having this discussion with you directly. But first, I thought that we should differentiate between the public engagement and the patient engagement here. And those are two different concepts, although they are related. As you know, patients are members of the public, but at the same time, the public has interest in having good patient care. But also engaging them differently has different aims. Usually patient involvement is directed towards improving quality of patients, versus the public engagement is a broader concept and usually is directed towards aligning the hospital policies with the values of the communities. So when I think of the patient and public engagement, I ask myself, why do we need to do that? And who are the people who we need to include? And how can we do that? So I think that the answer to the why is probably the easiest. It's the first thing, it's the right thing to do. And also when hospitals show commitment to public and patient engagement, it's really showing a clear sign of their commitment to move away from paternalism. We are very familiar with the paternalism on the patient level and the individual level, but when we change policies, that means we are also moving away from it on the systematic level. It also, science and research has shown that we have better patient experience rates when patients and the public are involved in creating policies, because they feel they have a skin in the game. We also know that patient and public engagement shows better safety and quality rates because there's also better compliance rates. And also from organizations' perspectives, it's more lucrative and financially beneficial to them when the patient and the public are more involved. Now, the more complicated question is who and how can we represent the patient and the public in this? And I'm going to try to lump these two questions together. And I'm going to piggyback on Dr. Yang's example of the patient, family, and advisory councils. And as you learned from Dr. Yang, that the mandate to have patient family PFACs, patient family advisory councils, is recent. I think here in Massachusetts we had the mandate in 2009 to achieve those councils in 2010. It's I think important to note also that not all the states have these mandates. And just for people who are not familiar with these councils, the way it happens is that you have hospital representation on a leadership level, but also you have members who are from the community who are invited to serve on these councils. Now, one of the challenges that we have is that you can only invite so many number of people to serve in these communities, and it's usually an application process. So basically, the hospital or the organization are choosing their partners, and there are certain criteria for that. Most of the times, my experience is that members of the patient family advisory councils are either previous patients, chronically ill patients who have been in the hospital system for quite a while, or family members and close people to these patients. And it's my observation that we rarely include people from the community who are not necessarily directly included, or members as patients in these organizations. As you might also imagine, there is a diversity and inclusion question here, because in order for you to have diverse population, for example, who speak different language, then you would have more resources for it. You would have interpretation during that. And unfortunately, that's not always available for these councils. And there's also a question of commitment for members of these councils, because that requires people are going to take time from their day. They're going to have to park in the hospitals. Usually we can offer that, but there's some time commitment and effort commitment. And the bigger question is, do we really represent the community within these members of the council? And again, to have an effective PFAC, you would need to train your partner in these, you need to train the members of these councils. One of the challenges that also we find is that after you train these members, they require time to be able to participating effectively in policy making, and suddenly their term is out. It's different, it's expired. So you would have to partner with different people. So that's also, the other question that, or the challenge that we have, when we choose members to join PFACs, is how we can balance opinions and perspectives within these councils, because you want to make sure that they represent the community and their interest, but also want to make sure that you have a balance of that. You want to make sure that you include everyone in the conversation. Naturally, when we choose our partners, we try to have people who think like us, who also usually would agree with us. Oftentimes, we do not include people who disagree with us. So that's one of the challenges for the PFACs. Another issue is that, sometimes there is a privacy concerns because you cannot share all the information and data with PFACs members. So that becomes an issue. Now, I don't want to sound very pessimistic. PFACs are really great, and they really inform policies, and they weigh in very positively in certain policies. For example, visitation policies and vaccination policies. I think specifically for visitations, for visiting hours, their opinions become very valuable. Now, the other example that I want to share away from PFACs are patient advocacy departments. And when we hear the term patient advocacy, there is a few things that come to mind, and we need to make the differentiation. There are the patient advocacy groups that communities might have to specifically tackle a certain thing, a certain disease that we have, advocacy groups that, they work towards improving things around it. But within the hospital system organizations, when we say patient advocacy departments, it's usually, or also the other name for it, the patient relations departments, are usually the departments that receive the complaints and the grievances from patients. And this is also from patients and the public. Sometimes people who are not patients call the hospitals, and they play, I think, an important role in informing the hospital decisions and policies, because when you get this information, that usually covers the other side, or the other mentioned with the PFACs, in which here you can get the people who disagree with us. So incorporating those opinions and becomes very important. The issue with that, again, is that mostly those are angry patients who they want to usually focus on quality, but also, as you said, sometimes people who from the public call, regarding, when they have a concern about a new department that has started in the organization that they feel it doesn't align with the community's morals or the community's values. So they share their perspective. The challenge becomes in trending these and collecting this data, because those are only individuals who have very strong opinions, and it's not sufficient for these voices to inform policies on the hospital level. The other issue here is that there is an inherent tension in the actual work of the patient advocates, because they have dual commitments and moral commitments to both the hospitals that they are employed in, but also to the patients. So finding the right balance into getting the opinion from these patients policy becomes very challenging, because by the end of the day, these advocates are getting their salaries from the hospitals. The other way that usually we can get opinions from the public and from patients is surveys. And I'm gonna also be clear based on my experience is that we are really good in sending surveys to patients. We are not as great in surveying the public. So we usually get only the perspective from the patients, not necessarily the broader perspective of the public. And usually we have the surveys on a very standardized questions. Tailoring questions towards specific policy is a challenge on the survey level, because you will have to comply with certain regulations. Sometimes for sure it requires some time to get the opinions, and you don't know what's the influencing factors for the patients when they share this opinion. So it gets a little bit tricky. And the other form is in which organizations also could gain information and from the public and the patients are town halls and open forums. And that's where deliberations happens. The challenge with that is that usually they are not super frequent, and there is no good feedback mechanisms in these forums. It's usually you receive it, maybe in 6 months or a year, you meet, you share an update, but you find different audience. So that's one of the challenges for town halls and the public forums. That being said, there's so many other opportunities to engage the public and patients. For example, digital platforms. But that also requires people to have the knowledge to do it, the ability, they have to have the devices, the access. So, but that's, I think, one opportunity for organizations and hospitals to improve in getting the patients and public opinions. And also, I'm a very huge fan of the narrative approach. Getting the public and getting the patients to storytelling to the leaders of the hospitals, that will inform and will help leaders to recognize the importance of involving public and patients in policy making. With that, I will get back to our group to have a discussion.
All right, thank you so much, Basil, and thank you again to Julius and Erica for your incredible contribution. In a few moments, we'll open things up to our attendees here, both in the room and virtually, for questions that you have. Those who are joining virtually, please feel free to start putting your questions into the chat. We'll get to as many of those as we can. But before we do that, I'm going to hand the proverbial baton to Charlotte Harrison to lead a little bit of discussion amongst our panelists.
Thank you, John. Basil, Julius, Erica, you have given us really an extraordinary set of insights from your experience and your reflection on this topic. And I'm wondering where you might want to go if it was just the three of you speaking to each other, having perhaps a chance for one follow-up question, given the time that we've reached today. So I know the audience is eager to speak, but does each of you perhaps have a question, or even if two of you have a question, we would have time for a little interchange. And you can just begin to speak or wave your hand as you like.
If I may start with a question. So my question is to Dr. Blackshire. You know, public deliberation is very interesting, but to me, and again, I come from a patient advocacy perspective, there is a power difference here in the form of knowledge. We have the organizations and the hospitals who have a lot of knowledge about what they are doing, and we have the public who we tend to fail in educating them about that. So how can we ensure having fair and effective deliberation when we have this inherent knowledge gradient?
Basil, I appreciate the question. It's an important question, and it's one that often comes up and whenever talking about public deliberation. This isn't exactly your question, but the question I often get, oh, surely the information is too complex for people who don't know all the facts and all the information. And I guess what I would say is there are two aspects of your question. One is power differentials and power dynamics, and one relates to just the complexity of information that, that is the subject matter, right? Health and healthcare. And I guess what I would say is, one, I would go back to a piece of evidence that I shared with you from the randomized controlled trial that was funded by ARC, which is that and it's maybe hard for we subject matter experts with letters after our name to believe, but if we do our job and really translate complex information into plain language and find experts who can talk about it in non-technical terms, people really can understand the information. Managing the dynamics of power differentials, whether it be on a PFAC or a CAB or within a public deliberation, is another matter. And that, for that you need many things. It's how you structure the conversation. It's how you train your facilitation team. They need to be exquisitely trained. There are a lot of kind of guardrails you can put around that discussion to help control that. And I guess so I don't know if that is a fully adequate response, but I have witnessed, and those I sort of travel with in this world of deliberation have witnessed, and we have some evidence that people are surprising. People will surprise you. They are remarkably good at having very nuanced conversations about really complex information. They might not use the language we use, whether it's in the space of, ethical terms and ethical constructs and scientific facts, but they can talk about the information. I think if we do our job right, they will surprise you.
Thank you both. Is there another question? If not, I have one I'd love to. Oh, yes, go for it, Julius.
I guess perhaps. Sorry. Apologize. Thank you. Dr. Blackshire is perhaps related to that. And I think recognizing more and more, it really emulating what we learned from engaging patients is that professionally, I have access to understand scientific method and evidence base for treating conditions. And I know that, but we probably used to assume that's all there was to know that was relevant to treating patients. And I think now we clearly understand that understanding what the patient's own experience is just as important as to, whatever the science shows about treating the disease. So the experience of illness is the patient's own, and that I need to learn from if we're going to reach the right decisions about care. And I think that's similar to what I think we're learning more and more about in terms of our larger initiatives. There are so many broad healthcare initiatives in the United States that frankly fail, despite what we have evidence to suggest should be effective, but it doesn't have. We don't understand enough those who we're trying to help with whatever intervention. I guess related to that, you mentioned that one of the challenges in thinking about in deliberative process is really granting weight to perspectives versus evidence or perspectives. And perhaps this gets a little bit to, I think, Palmer into the chat. So like, what is the outcome of these deliberations in terms of what is the rules for, okay, what are we going to reach and how do we weigh the perspectives of perhaps the public or the patients versus what the evidence are in terms of deciding what to do?
Yeah, thank you for all of those comments. You're singing to my heart there with regard to your first point about, you know, subject matter experts, technical experts. They know the science. They know their business, but these decisions, these are value-laden decisions. And it shouldn't be just the subject matters experts or the technical experts or the physicians' values that matter, right? We see this in clinical decision making. We see this on and on. And it should be the same for the policies that affect people who are going to have to live by them. Basil, I really appreciated it that you noted all of that good science that we have about adherence and compliance and uptake, when in fact people are engaged and they get to inform the practices and policies that are affecting them. I kind of referred to this blithely as, you know, things go better when you actually talk to people. And to your point, Julius, about, you know, just, you know, we invest millions of dollars in these very sophisticated interventions that are supposed to improve people's health. And very often they simply fall flat because we actually haven't talked to the people we mean to help. So it's well intentioned, but it is a waste of money. But to your question, and you were cutting out a bit, Julia, so I want to make sure I understand your question. I think it relates to a question in the chat about, okay, so we're engaging members of the public in this discussion about this policy or practice, and who has decision-making power? Like, you know, how should we imagine what happens to what we sometimes call the deliberative output? And this is an area of a lot of discussion and debate among people who do this sort of work. I mean, what does it mean for the judgments or the recommendations or the views of a deliberative body? What does it mean for that to inform a policy? So let's say there's a live wire policy. If a hospital is trying to figure out their masking policies, right? We know there's all this variation and heterogeneity from hospital to hospital, from region to region across this country. Does it mean that what people say in that deliberation becomes policy? Well, rarely is that the case. But what can be very useful about a deliberation, I mean, and this is something that I would say, well, let me back up. We need to keep in mind that when deliberations are done, they're usually somebody's sponsoring them, someone's paying for them, whether it's happening in the civic space, the academic space, the policy space. And so experts are designing them, and usually somebody wants to hear what people have to say. But then here's the tough nut. What do we do with what people say? And I would say to the person who asked the question in the chat, if we tell them we're going to take them seriously, and that if we're not really careful, I would say, about what we're going to tell them, what we're going to do with that information, and then we just ignore it, you will lose trust from that community, because it's not just the people in that room, maybe some 20 people, maybe some 25 people. They'll tell everyone, well, they convened us for 2 days and then they did nothing. Yet another way in which we're being ignored, right? But deciding to take that information in need not mean saying, oh, well, these 25 people say to do this, and thus we're going to do this. It can inform policy and other, I mean, there may be instances where if you really feel secure and really confident about the representativeness, another serious challenge that I understood you be speaking to, Basil, of the people in the room, then maybe you could do something like that. But knowing what people's values are and knowing what people's concerns are and knowing how people are thinking about, say, risks and benefits, and getting a sense of that sort of value landscape, that normative landscape, can inform leadership's view about what to do, right? And if you tell people, we aren't necessarily going to enact what what you think is the right thing to do. And here I'd say, be sure you frame your questions carefully. Question formulation really matters. But we're going to take seriously your concerns and your values in this room, and here's how we're going to do it. And then what's really great is if you can circle them back to them and say, here's what the leadership did. Right? So that there's this co-learning. I mean, that's the thing that I hear both of you speaking to, this is the transformative potential, right? Where it's just not a one-way communication. One-way communication isn't participation and it isn't deliberation. Maybe it's engagement, as when we do a survey, right? We're getting top of mind information from patients, less so maybe from families, less so from the public. And that's useful information to have, but that's not transformative because there's no dynamism in that circuit of learning. So I'm saying too much, but I hope I've begun to address your question.
Thank you all. I think that's really responsive in going the next step from what we've talked about as common current practices in hospitals. I mean, hospitals clearly value patient input, and they may, and also the input of communities that are directly affected by the determination of need process and the kinds of community interventions that a hospital might be able to offer. When you take the next step from a patient or a directly involved stakeholder and go out to the public that has really, they know they might become patients of your hospital, but basically they're more or less disinterested in that way. They don't have an investment in the institution, which makes it more intimidating to bring them in, more concerning. On the other hand, they don't have, they have perhaps a broader range of perspectives that might be helpful to the hospital. And I'm wondering what might be a next step for institutions or for people within our institutions who would like to, encourage consideration of public deliberation. I mean, our audience is, I would judge, mostly made up of people who work with ethics committees, for example, and ethics services, or others who are really interested in community and public participation in thinking about some issues that face our hospitals in setting patient-facing policy. So would anyone want to offer just some thoughts about next steps within an institution just to bring this kind of thinking and the concerns and responses perhaps that Erica has shared, to the attention of people? Or what are other ways that, over time, consideration of these opportunities might be made more visible and more better understood by leaders in hospitals?
And if I could piggyback and add in one piece, that how we can ensure that engagement is truly inclusive and representative, as a couple of our speakers have already mentioned. In some ways, a lot of the engagement that we have, whether through PFACs or community members on our ethics committees, these, as a couple of people mentioned, can be seen as insiders and not necessarily as true representatives of the community at large or of the public. And so how do we make sure that whatever this engagement is that we're going to do is indeed including the folks that we hope that it will?
Well, I'll just say something really quickly. And I think one of the first steps that an institution should take would be to identify those opportunities where public input would be welcomed and useful. And Julius, I was just awestruck by the wonderful range of ways in which your institution engages the public. And community health assessments are a brilliant opportunity especially for nonprofit institutions, right? They need to demonstrate community health benefit. What better thing to do than engage the community in asking them what they see as their challenges to health, their opportunities for improving their health, their understanding of the barriers to health. And that's great. And then, where deliberation could build off of a community health assessment, how it's kind of down the trail of that is to say, okay, here's what we understand to be the challenges, the opportunities. Let's prioritize what we ought to do, right? That's a perfect opportunity for deliberation. I mean, it sounds like you all are the exemplars of this, but that would be a first step, Charlotte, which is just what are those decision-making junctures? Where are we making decisions about things that impact the communities we serve, the populations we serve, and the broader public? Most of us are going to become patients, whether we like it or not. We're all future patients, where we think public input and serious, deliberative public reflection would be useful.
Thank you, Erica. And I think an example might be the chronically problematic decisions around policies about potentially inappropriate and futile care, where you often have camps of hospital, people involved in a hospital, patients, families, and clinicians, but we don't necessarily have benchmarking from the public on what might be people's values in that sort of gray area where there's not, really a lot of agreement professionally as well as among patients about what should be done. So just one thought, but I think that as institutions begin to consider what might be an advantage of having a general public, perhaps things will emerge. I really want to thank everybody. I'm sorry that for audience Q&A, I'm happy we were able to address the one question that's appeared in the chat. I apologize that given the time, we're really going to move forward to conclude the program. But this will not be the last program that one or both of our consortia will feature over time to consider this particular topic and the following up with other institutions. So if you are interested, please stay posted. The website will, at the Harvard Center for Bioethics, will have a video of today's program that can be picked up. It'll be posted in the next few weeks. And you can also find there announcements of additional programs or subscribe to the center newsletter. I want to say a word quickly about the the next program of the Organizational Ethics Consortium to take us out. And John will also have a final announcement. But first, I just want to deeply thank our panelists, Erica and Basil and Julius, for giving us a really rich picture of where we are, where some people have gone, where our institutions might go, and are thinking, how much really deep thought has been given to patient and community engagement, which is certainly a foundation for a larger discussion. So thank you. And thanks to the audience for being with us and for thinking with us and posting that question in the chat, which was very productive. I'm sure many people had it. Quick announcement about January, and I'm mainly targeting people who might be interested in a public discussion of policy formulation in hospitals. We have, how many people in the room, I wonder, were involved when, recently there was a fear of widespread shortage of ECMO oxygenators, and how are we going to have enough ECMO circuits for the patients who really need them to survive. Going to be, did anyone, is there a hand raise? Anyway, in January, we're going to hear from a group in the Pacific Northwest, which felt that they had about 2 weeks to get a policy in place. And it needed to be one that was supported by 4 ICUs, the surgical services, and hospital leadership. And they're going to talk about how they did it, how they built on some regional planning that had been previously done, and the challenges and questions that still remain. So I hope that people will join us if you have experience or interest in that topic. And now I believe John is going to carry us out with a final announcement.
Thanks, Charlotte. Yes, that will be a spectacular session at the Organizational Ethics Consortium in January. We will not have a Clinical Ethics Consortium in January, but we'll return in February. And before we close, one quick plug. We will be having again the Harvard Ethics Consultation Skills course this coming spring, and registration is open. You'll see on the screen now the QR codes and pricing for both HMS affiliates and for the general public. So feel free to reach out to us if you have questions about this. Thank you again to everybody for joining us, both here in the room and virtually. Thank you so much. Happy December, and we will see you all soon.